Good morning, everyone. I think we'll get started. Thanks for joining. Good morning, good afternoon, good evening, wherever you are. I'm Lola Walker from the HIV section in UNICEF, and pleased to have you all join us on this important webinar. We have an ambitious agenda, and I will do my best to make sure that time is managed as best as we can. For the lineup today, we'll be starting off with a few remarks from Shafiq Essaji, the program lead in the HIV section, UNICEF New York. Also, a few remarks from Tamara Brisenow, adolescent development specialist here in UNICEF New York. And then we'll have a few remarks from Shirley Mark Prabhu, who is the elimination of mother-to-child transmission, adolescent health, and HIV specialist based in IAPRO in Bangkok. We are pleased to have Nomika G. We've been recommended to call her G, from the government of the Philippines, who will be speaking to some of the experiences in the Philippines addressing age of consent as a barrier to the service access and adolescent engagement in their care. And then finally, we will have Kip Beardsley, a dear colleague from the Palladium outfit, based here in New York, who has been grappling with these issues for about a year and a half and has worked with numerous institutions, experts, and global stakeholders to develop an exciting framework that positions maturity-aligned consenting as a new tool within our collective response for adolescent children's, adolescents' health and HIV. I think a few housekeeping issues. If you have a question, please do feel free to let us know by sending a message in a text box. We will then call you to either speak into the mic, or if we can't make that work, we will read out your question and then we'll have the appropriate speaker respond. Also, if you could mute your lines, it will help to manage feedback as the lines are quite sensitive and we expect quite a few attendees from all over the globe. So please do mute your lines in as much as you can. The lines that are not muted, we will try to mute manually. We will indicate when there is need for, when we'd like to open the conversation for questions. So there will be no questions for the first two presenters, Shafiq and Tamara, as well as for Shirley. We would like to direct the bulk of our questions to our speaker from the Philippines and then to Kip. We'll take a few questions after the presentation from the Philippines, so 2 or 3, and then we'll try to load the majority of the questions towards the end of the webinar. So with the housekeeping issues attended to, I think we'll have it over to Shafiq.
Lola, thank you very much, and thank you all of you colleagues for joining, especially to our colleagues from East Asia and the Pacific region. We know it's very late for you, so I will keep my comments very brief so that we can get on with the business of the day, which is to discuss some innovations that can help us to better understand our approach to informed consent amongst adolescents. This issue is, of course, of fundamental importance to child and adolescent access to effective interventions, not just for HIV prevention, but also for sexual and reproductive health interventions in general. And as we begin to really engage adolescents in our work and engage with adolescents in the policy decision-making that goes on for their best interests, we also recognize that adolescents must be at the heart of the response for adolescents. So we recognize that they must have agency in the sorts of programming that we develop, but I think our thinking on how we implement that in the field and how we give access to adolescents to services falls short of that ambition to give adolescents the power, the agency, the choice to help make informed decisions about their own health. So I think there's a misalignment here between our global ambition to empower adolescents and the practical realities of how we deal with consent for adolescents in healthcare settings. UNICEF in 2017, in collaboration with UNFPA and UNDP, conducted a global landscape analysis to map age of consent policies across key services such as HIV and sexual reproductive health for adolescents. And this highlighted some critical inconsistencies in the age of consent policies across and within sectors. In many countries, we found that there were different policies enacted for different types of services that were in place, and even variation from one location to another, from one site to another. So this is not an easy issue to fix, and WHO guidance, although it's extensive on adolescent health, adolescent sexual and reproductive health, HIV prevention and testing, is relatively silent on the issue of specific minimum ages of consent, even as there are generic statements made about the recognition for harmonization across policies. We also understand that specific populations of children, especially children who are orphaned, children who are living on the streets, children in child-headed households, children who are in child marriage, are in need of protection and prevention from sexual exploitation. So there is a dual agenda to some extent that recognizes our need to protect children in some cases with legislation that ensures that they are not exploited, but also to free up children to give them access to services which are essential for their health and well-being. And I think our objective today is to try to unpack this to some extent and see if we can come to a place of understanding where we can try to combine these two issues. And I think the presenters today will hopefully shed some light on how different countries have taken innovative approaches and how different frameworks and thinking can be applied to try to address this conundrum. So let me hand over to my colleague Tamara from the Adolescent Department here at UNICEF to give us some additional remarks.
Thank you so much, Shafiq. And maybe I'll take us a little step backwards, but you talked about the importance of agency choice for adolescents and how important it is to both protect them but also make sure they're free to access services. And a lot of that is rooted back in something that goes back 30 years ago, which is, of course, the signing of the Convention on the Rights of Children. And this year is indeed its 30th birthday. And I'm sure that the world leaders who put it together at the time would never have expected it to be the most widely ratified human rights treaty in the world. And that's always important to remember. The rights of children are important to everyone around the world. The four core principles of the CRC are non-discrimination, the devotion to best interest of the child, the right to life, survival, and development, but also this respect for the views of the child. Now, this last one is particularly important, but it's also proved quite contentious over the years. It's called Article 12, and it represented a new provision in international law that recognized the fact that most children below the age of 18, unlike adults, don't have the autonomy or the independent rights of decision-making. And that's why the CRC was so important in terms of articulating actual rights for children, because they're not mini adults, they have their own rights. And this Article 12 about listening and having them have an input on decision making is really important. And unlike other civil rights, like the freedom of expression, the freedom of association, the CRC requires that that rights holders actually ensure that children have that right. And these rights holders are parents, they're teachers, they're health providers, they're government officials, and other adults. Those are all duty bearers towards children. And they are obligated to make sure that opportunities are provided for adolescents to be able to express their views, but also be involved in decisions and actions which affect them. And that's what we're talking about here today. So why is this important to consent? Well, some laws that we have on the books give adult-like rights to adolescents and others don't. So you can have a situation where in one country, for instance, children of 16 have the right to drive, to smoke, to serve in the army, but they might not have the right to vote, get married, or do other things that we sort of see as adult-like rights. And this contradiction in legislation and policy can be confusing, but also sets us up for problems. Another example is in Brazil, where we worked hard to reduce the age of voting because young people really wanted to have a say in the democratic process. And the government then turned around and said, well, that's fine, you can vote earlier. That also means the age of criminal responsibility will be lowered. So then children could be locked up in adult facilities. That's not what we wanted. So it's really important to get this balance right between protecting children, which is what the Convention on the Rights of the Child is trying to do, giving them specific rights, but also enabling them to have voice, involved in decision making, to be allowed to do and to make choices for themselves. So this is this balancing act that we're trying to get right. And when policies and legislation contradict each other, it's not an easy situation. So thank you and welcome. This is going to be the first in a number of webinars where we're going to be looking at this issue, and we really welcome inputs from the field and the region in terms of their experience in trying to get this balance right. Thank you.
Fantastic, Tamara. Thanks so much for the survey of the policy landscape and anchoring within the CRC and some of the attendant policy issues. So we'll hand over to Shirley Mark Prabhu, who is an EMTCT adolescent health and HIV specialist in IAPRO, to give us a sense of some of the work that's being done in the region and the implications of age of consent as a barrier to adolescent service utilization, adolescent engagement in their care, and then some of the work that they intend to be doing over the next couple of years. Over to you, Shirley.
Thank you, Lola. Good morning, good afternoon, good evening, everyone. So I'll start off with a little overview on the HIV epidemic in Asia Pacific. So in Asia Pacific, while the overall epidemic trend in HIV is declining, we are seeing an expanding epidemic among people who inject drugs and men having sex with men in different parts of the region. There is a re-emerging of epidemic in a few countries, and worryingly, this re-emerging epidemic is disproportionately affecting adolescents and young people. And evidence shows that those adolescents and young key population who are most at risk of HIV infection have the lowest levels of access to HIV prevention, testing, and treatment programs. And in the region, 2 in 3 young people from key populations do not know their HIV status. So over the last few years, UNICEF, together with UNAIDS, UNFPA, UNESCO, and the Young Key Population Network, as part of the interagency task team on young key populations in Asia Pacific, have advocated for access for SRH and HIV services for adolescents and young people at risk of HIV. And as part of this review, as part of this effort, a review of laws and policies affecting young people's access to sexual and reproductive health and HIV services was undertaken by UNESCO and partners. And some of the things that we saw in relation to consent to HIV testing were laws and policies related to consent are absent or clear or contradictory. Legal age of consent is set at a higher age than average age at which adolescents become sexually active or experiment with drugs. And as we know that the age of sexual debut is now becoming much lower than before. And as Shafiq mentioned, there are no legal provisions or policy guidelines on HIV testing of unaccompanied minors or those parent, legal guardian, or next of kin cannot be located. So abandoned orphan street children and minors engaged in commercial sexual exploitation, there is no legal provisions in the law. And in practice, both service providers and young people are often confused about the legal rights of young people to access SRH and HIV services and information at specific ages without parental consent, particularly during adolescence. So there are 11, next slide please. There are 11 countries in Asia Pacific that have now included provisions for independent consent to an HIV test, and there are discussions happening in other countries in the region. Next slide, please. So we'll take a look at a few countries. And so here we have Vietnam. The age of legal capacity to independently consent to an HIV test is 16. And in Fiji, a person under 18 may consent to an HIV test if, in the opinion of the person providing pre-test information, the minor is capable of understanding the nature and consequences of an HIV test. And in 2014, the Thailand Medical Council revised the guideline to include the right of under 18 to take a test without parental consent. And the guideline encourages health workers to counsel those younger than 18 so that they fully understand what an HIV test is and its implications. And in Bangladesh, while we know that law reforms take a long time, the Ministry of Health and Family Welfare issued an interim national directive based on risk or vulnerability assured that allows HIV and SRS services without parental consent to most at-risk adolescents who are below 18 years of age, or who are orphans, or who do not live with their guardian or live outside of parental consent. And we have Philippines also, and we'll get to hear more about it. So there are ongoing efforts in the region, and as part of the interagency task team on young key populations, UNFPA and UNESCO are now in the process of finalizing a legal advocacy toolkit on young people and the law in Asia Pacific. So this will be something that will be used to capacity build in the countries, and also to advocate for the removal of these barriers in the countries. So I'll stop here, and thank you.
Thank you, Shirley. We look forward to hearing further updates as this series continues on some of the work that you will be doing on the legal advocacy toolkit as it is finalized and as it is rolled out and implemented. That body of work will nicely inform some of the work we are doing at the global level. Give us a moment. We have a bit of a technical issue that we need to resolve. In the meanwhile, I'd like to introduce our next speaker from the Philippines, Nomina Mojica, or G, who is from the Council of the Children's Welfare in the Philippines. G is the head of the policy unit of the Policy and Planning Division, and also is concurrently the head executive assistant to the executive director of the Council for the Welfare of Children. With 23 years of experience in child rights, G has been involved primarily as the focal person of the CWC on HIV/AIDS, juvenile justice, amongst other concerns and issues. She's been a long, passionate advocate for the rights of children, especially those who are at risk, and we really do look forward to hearing some of the groundbreaking work that's been done in the Philippines under her leadership and through a broad constituency of partners and advocates. Do we have you, G, on the line?
I could hear you. Hi, everyone. Do you hear me?
We'd need you to speak a bit closer to the microphone, but otherwise we can hear you.
Is this okay now?
It's perfect. Thank you.
Okay. Again, hi, everyone. Good morning, good afternoon, good evening for those who are here from the Philippines. Mabuhay. Yes, I look at the slide and I have there Normina Mojica, but again, I prefer being called G. I'm glad you made time to join us in this webinar where I'll be glad to share our journey in developing the protocol on proxy consent here in the Philippines. And for a long time, the Council for the Welfare of Children had really been working on issues of children concerning HIV and AIDS, where before we were a voice in the wilderness in terms of making it more of a psychosocial issue or not just a medical issue where it concerns HIV for children. And that's where we were able to bring in other service providers other than our health workers when we talk of HIV. The Philippines, of course, is a low middle income country with 104 million population. 20% of that group population are adolescents aged 10 to 19. And going back to the previous slide, let me just give you a bit of introduction of my agency, the Council for the Welfare of Children. It is the focal government interagency body mandated to coordinate the implementation and enforcement of all laws on children. Part of our mandate is to formulate and evaluate policies, programs, and services relative to the development of the general well-being and protection of the best interests of children. And we have our council board. It is composed of the different department secretaries, or for other countries, the ministers of different ministries like the social services, Ministry of Health, the education, labor and employment, justice. It's a whole gamut of national agencies that have really concerns on children. And what is unique in our council board is we have 3 private individuals, and one of which would be a young person. Because in CWC, we live to that particular mantra of having a child participate in policy making. Okay. And well, as an apex agency on children's concern and as a coordinating body, we then monitor the implementation of the UN Convention on the Rights of the Child. But CWC has been in existence even way before the UNCRC. We have been there since 1974. And to address the different issues and concerns on children, we have different structures. And one of the key structures that help us in terms of developing the proxy consent, the protocol on proxy consent, is the Committee on Children and HIV and AIDS, which has been recently revitalized. And the structure primarily responds to the issues and concerns on children and HIV. In the Philippines, we advocate that any work concerning children should be a GO and NGO collaboration. It should be both government and the civil society working together, addressing the issues of children. Next slide, please. Well, in the Philippines, there are different issues that confront children and young people. We have the high teenage pregnancy rate, we have the increasing rate of HIV infection. In fact, Philippines belong to one of the 7 countries with an increasing rate of new HIV infection. And we also have a high overall prevalence of violence against children. This is based on a study we had in 2016, the National Baseline Study on Violence Against Children. Okay, as one of the having the highest teenage pregnancy rate in the Southeast Asia and Pacific region, we really have childbearing from 8% to 203 to 10% in 2013. And based on another survey for young adult fertility and sexuality, it also showed an increase in teenage pregnancy from 6.3% in 2002 to 13.6% in 2013. When it comes to the new infection, HIV infection among adolescents and young people, we have especially seen the increase among male and transgender having sex with male. UNAIDS reported the global HIV epidemic in Asia and Pacific finds annual infections have more than doubled in the Philippines in the past 6 years. A recent behavioral risk survey conducted in 2015 showed the average age of sexual debut among male and transgender having sex with male was at 16 to 17 years old, and this includes receptive anal sex. However, the average age at first HIV test was not until they are 22 years old. So there, as I earlier mentioned, there is a high overall prevalence of violence against children in the Philippines. Now, the Philippines, in its attempt to address these issues of HIV and reproductive health, has passed two laws. We have the two laws. We have the Philippine AIDS Prevention and Control Act, which was passed in 1998, and the recent one is the Responsible Parenthood and Reproductive Health Act, passed in 2012. However, it's sad to note that these laws have had limited access of minors to sexual reproductive health services, including the HIV services and testing. Why? Because it called for parental consent as a requisite for services. They're now the policy barriers that we have to deal with in the Philippines. Next slide. Now, to solve this, for us to be able to reach out to children and young people who are not getting tested because of the realities or their situation in their lives, we have to have proxy consent done by the legal service providers. And proxy consent would refer to the process by which people with the legal right to consent to medical treatment for themselves or for a minor or a ward delegate that right to another person. In the case of the Philippines, you have the social workers and the physicians to do that. Now, who can be provided with proxy consent? All children, provided that these children are recommended by the social workers and are deemed by these physicians to be needing proxy consent. Provided further that social workers have exhausted all means to reach the families of these children or to locate the parents, because we believe in the Philippines, the first support system should be the family. But in the cases of the children at risk, most of them you find they're stuck in that situation wherein they may not be with their families or they are not able to reach out to their family or parents to give them those consent. So in the process, if they cannot give that consent, that's where the state comes in. That's where our state workers in the persons of the social workers and the physicians can come in to give them that consent. This protocol aims to increase the uptake of HIV testing services emanating from the need to protect the child who may have come into contact with infected body fluids through different situations, either through sexual acts, through needle sharing, or to other ways which increases the risk of the child to get infected by HIV. It also aims to empower the child's own views and understanding of HIV testing by being aware of its possible impact on the emotional well-being and physical health of the child. The protocol actually complements already existing national laws. We have the Presidential Number 603, otherwise known as the Child and Youth Welfare Code of 1974, which created, by the way, the Council for the Welfare of Children. And this PD 603, this law emphasizes the doctrine of parens patriae, which means father or parent of his country. It refers to the inherent power and authority of the state to provide protection of the person and property of a person non sui juris. We also have the Republic Act number 7610. It's otherwise known as the Special Protection of Children Against Child Abuse, Exploitation, and Discrimination. Actually, for other service providers, they call this the Anti-Child Abuse Law. Well, the following state policies and principles are stated in this law. It is to provide special protection to children from all forms of abuse, neglect, cruelty, exploitation, and discrimination, and other conditions prejudicial to their development. It also protects and rehabilitates children gravely threatened or endangered by circumstances, and to promote the best interests of the child in all actions concerning them. As provided in Section 10 of that particular law, there is immunity of the officer taking the child under protective custody of the implementing in its implementing rules and regulation. The duly authorized officer or social worker of the department and the assisting police officer or barangay official or village official for some, if any, who shall take a child under protective custody shall be exempt from any civil, criminal, and administrative liability therefore. We also, of course, have the law that uh, for AIDS, which is the Philippine AIDS Prevention and Control Act of 1998, which is RA number 8504. Of course, this has been already amended by the new law that has been recently passed. Now, let me just, next slide, please. Let me just get to a story of Maria. Maria is actually a transgender who has been sexually active since 14. She experienced recurring colds and bloody coughs when she was 17 that she suspected she has HIV. She was referred to an HIV counselor and was advised to take HIV tests. However, again, there's that impediment. She was a minor. She was very afraid to secure consent from her parents for fear of being disowned and out of shame. She was referred to an adolescent-friendly clinic in one of the HIV high-burden cities, providing proxy consent and case management. Thereafter, she was tested with the support of a social worker and a team of healthcare providers. Having tested positive, case management called for the involvement actually of parents. Thus, the multidisciplinary team engaged her parents to initiate treatment. After that, Maria's mother was grateful for the help of her daughter, for the help that her daughter received. Now, Maria is back in shape. She pursued her dream, continued her studies, and is now an active youth leader and an HIV advocate. Maria is just one of the many faces that gave face to these numbers we have in this table. The table shows that 8% of the total estimate of 1,976 compared to the other age groups have ever been diagnosed with HIV. This just underscores the fact that due to the issues that confront these children and young people and the policy barriers that we have, there's really a need to formulate and develop a proxy consent protocol to increase the uptake of HIV services among children and young people. Let me just, on the next slide, let me just walk you through the processes we had. Next slide, please. Yeah. Okay. This is what we undertook for us to be able to develop the proxy consent protocol. Of course, we have to review frameworks, policies, and laws in relation to adolescent access to services. As I said, being a country that gives so much weight in how parents actually should be the ones protecting their children, we have to make sure that the guidelines that we'll be developing does not run contradictory to any other laws that we have. Okay, so we have to review that. We have to document the service provisions to adolescents in selected sites or demo sites. But what was key was our consultation with the regional offices of the Ministry of Health and implementing partners. We cannot, definitely, we cannot do it alone as the Council for the Welfare of Children, but we really need to have everyone on deck, everyone delving or helping in the development of the protocol. We have to define conditions in the development of algorithms and tools. We have to work with champions. We have to look for champions. Honestly, even if you have experts on board, we definitely need personalities or champions to help us push the advocacy that we were doing. I mean, for us to, the protocol initially was a hard sell. It is something not easily um, not easily being sold to, especially to legislators. Sorry, I have to say that, especially to legislators, to policymakers, to lawmakers, because as I said, we're used to adults taking care of children. Yeah. And we did so many consultations to validate conditions. And when you talk of consultations, you talk of multi-stakeholders in those consultations, and of course, the children and young people themselves. Okay. We also have to pre-test act. After we develop the protocol, we have to pre-test it, but by way of pre-testing it, we also have to capacitate the different healthcare providers who would really make the ball rolling, and actually test the protocol. And of course, as I said, this is not just a health issue. So aside from the healthcare providers or health workers, we have the social workers involved. And after this has been pre-tested, again, it has to go through some refinement, and you have to do process documentation. And finally, after several consultations, various meetings, getting inputs from the different stakeholders and even from the students, we were able to adapt the protocol and the provision of proxy consent for HIV testing. And this was adopted by the board of the Council for the Welfare of Children and also the Philippine National AIDS Council. Now, what is unique about these two councils? When we talk of the Council for the Welfare of Children, this is the council that has the say on children's concerns. We have all the ministries involved here, and who has a say in terms of taking care of children or making sure that the best interests of children are being cared for. And when we say the Philippine National AIDS Council, it is the highest policy governing body on HIV. So you see, the CWC is part of, well, we're regarded as the sounding board when it comes to HIV by the PNAP. So that's very important for us, for the two councils to adapt this. Okay, next slide, please.
Kindly mute your lines if you
Jetra.
can.
Again, what was very key for us is the meaningful engagement of children and young people. In the whole process of developing the protocols and in keeping with the principle of meaningful and ethical child and youth participation, these children have been consulted during the development of the proxy consent. And then I am happy to say that the Philippines had actually been noted for having one of the best practice of child participation several years ago when we have the National Young People's Planning Forum, wherein children and young people were brought together to come up with a strategic framework on the country response to HIV.
Please mute your lines if you are not speaking. Thank you.
Next slide, please. Okay. For us to have an integrated sexual reproductive health and HIV service delivery model, the proxy consent serves as an entry point. At the national level, the Committee of Children and HIV/AIDS, which includes various national government agencies, CSOs, and development partners, work together in a technical working group to guide the implementation of the model. At the local level, the model is implemented in partnership with civil society organization and non-government organization partners that are actually in charge of health service delivery, and the local government units for coordination, and with youth networks in charge of peer education. Adolescents are engaged in assessing the adolescent-friendly facilities, and if parents are supportive, they go through the usual process. For those who are deemed needing additional guidance, especially on accessing HIV testing services, proxy consent is provided. That's where we provide them the proxy consent. This is now part of the broader case management done at the facilities. And with the help of social workers or healthcare providers trained on case management, we are actually supported to access various services through the service delivery network. And as part of the protocol, the parents or relatives most of the time are also engaged with the child's permission, depending on the level of support. With support from UNICEF, this has been modeled in selected HIV high-burden cities, then rolled out to Global Fund sites to Save the Children and AIDS Society of the Philippines in 2017 and 2018. We're currently documenting experiences enrolling the plan using the protocol. And as a way forward, next slide, please. We wanted to ensure the institutionalization of the protocol, where CWC, together with its Committee on Children and HIV and AIDS, will advocate for the inclusion of the protocol in the implementing rules and regulations of the newly enacted law of the Philippines on HIV and AIDS. And yeah, we would be continuously monitoring the implementation of the proxy consent protocol and track the progress of trainings for proxy consent among service providers. And last, next slide, please. We would like to recognize or acknowledge the Committee on Children and HIV and AIDS members and partners from the national government agencies. We have them here. As I said, we have different ministries involved in the Committee on Children and HIV and AIDS, like the Department of Education, Department of the Interior and Local Government, Department of Health, Department of Justice, Department of Social Welfare and Development, the Commission on Human Rights, the National Economic and Development Authority, the Philippine Information Agency, the League of Cities of the Philippines Secretariat, League of Municipalities of the Philippines Secretariat, the League of Provinces, the National Youth Commission, the Philippine National AIDS Council Secretariat, ourselves, you have the CSOs, the Action for Health Initiatives, Achieve Association of Positive Women Advocate, the AIDS Society of the Philippines, Save the Children, Community and Family Services.
Wow.
You have the Pacific Action Foundation. You have the community per se with us. And you have UNICEF, of course. And again, we have the different non-government organizations within the local government units who help us to test this proxy consent. Thank you very much for listening and for letting us share our journey in developing the proxy consent.
Great.
Thank you.
Fantastic, G. You have a very enthusiastic group here in New York who I'm sure have questions for you. We just wanted to thank you for the work you've done building a broad coalition, a broad constituency to address a really difficult issue, a really sensitive issue, and for your sharing of some of the practical steps and the practical tools and instruments as you have navigated the course on this. I'm sure that we have some questions online, but we'll start with the room. Kindly do signal your intention to ask a question by entering it in the text box. Send us a text. We'll read the question out loud, and then we'll have Ms. G respond. And we'll take 2, 3, or 4 questions in the interest of time. So feel free to share all your questions. We'll take 2 to 3 of them if you're online, and then we'll read the rest off once we've had the final speaker on the webinar series. So questions?
Yeah, this is Chewe, the chief of the HIV section. Excellent, and thank you. I just have maybe 2 questions. One is, I know that changing policy or legal frameworks takes time. if you can just give us an indication as to how long this process actually took. The second thing that I wanted to just ask is, you're building this on a platform of social workers being engaged and adolescent-friendly services being adopting this approach. I just wanted to know, within Philippines, how widespread social workers are, because this might be a bottleneck in some countries. And then two, how well adolescents actually access adolescent-friendly services, because what we're finding, especially when we work with key populations, is that the clinic is the last place where these children want to go. So if we're working within a network of services, if you can just give us how that is organized, and where are the children most likely to attend these services? Is it in the clinics or outside? And how do the services that are led by civil society, for example, looped into the network?
Okay. Thank you for those questions. And, it almost took us 2 years to really develop
2 years.
the protocol. Okay. That was 2 years when we really had everyone on
Not
board.
bad.
Okay. But I'll be honest to say that we started advocating to have this protocol or these guidelines for adolescents a decade back. Okay. Yeah, I mean, the social preparation really took us time, to open the minds and the hearts of people working with children. As I said, uh, Philippines is a country where we give so much weight on how parents regard children, on how parents are protective of their children, or how adults look at children. So it's really very hard for adults to really give that empowerment to children. But as our agency, given our mandate and making sure that we have children on board in terms of policy making, we really have to touch base with different stakeholders. And I'm just very glad that while we were working on this, of course, not just because I have mixed here as UNICEF, but really UNICEF had a great role also in enrolling, in making sure that this protocol is developed. And of course, you have the different health service providers or health, uh, uh, and also social workers who finally opened up also that this is indeed a psychosocial issue. It's not just a medical issue. And it's actually the different factors put together that actually made this all possible. Of course, what also drove us to really pursue this development of the protocol is, of course, the data that we have an increasing new HIV infection, and where Philippines used to be among the low prevalence countries. It's sad to say that as the years pass, we became one of the 7 countries who have an increasing rate of new HIV infection. That that also is another factor for us to really, put our acts together and really start or make sure that the development of the protocol pushes through this time. And another is the passion of the different people who really work for the protocol we develop. You have the from and when I say the passion of the different people, you have people within the national government agencies. We have our civil society partners. We have our development partners, uh, and 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 of course, seeing the condition and the situation of more young people, uh, getting, you know, um, I mean, their condition is something very difficult to look at or or see.
Mm.
So that drove us to really make sure that the protocol was developed this time.
Thanks so much. And you also had a question about the capacity of the social workforce in the Philippines. Could you speak to that, Ms. G?
Yeah, right now, of course, I would say we don't have so many social workers right now. In terms of the making sure that their competencies are being make the protocol work. And now, I mean, we see the enactment of the new law as another challenge, and for us to pursue the advocacy that they ensure that this is part of the implementing rules and regulations. Because definitely, the mature minors, they're okay, they can be tested, but we still believe they should be guided.
Mm.
It should be a guided, independent access to HIV testing and services.
Perfect. We have another question from Nina, who has to drop off in a few minutes. Do we still have you, Nina?
Yes, I'm here. Can you hear me? Yeah?
Clearly.
Okay, great. First of all, thank you for organizing this. I think it's as some of you know, it's the issue that's very close to my heart. I think that I'd like to echo what Tamara was saying. It is the whole age of consent and minimum age legislation is a very, very important topic and a key issue that prevents a lot of agency of young people. So I think that the important piece here is to look at age of consent in these kinds of issues to HIV testing and sexual in a broader setting. So I think that what would be very interesting to see as we get into this work in more detail is to see how does that fit with other laws and what else is going on in the country vis-a-vis, for example, other behaviors. I'll give you an example. In Turkey, for example, there's something called the Romeo and Juliet laws. And the Romeo and Juliet laws in Turkey basically make it kind of is a way out for the young lovers who are having sex, and when there's a pregnancy case, is a way out for the young man not to end up in jail. However, if the family of the girl decides to pursue the boy is in jail. But if the girl is married to a 30-year-old older man, then nothing happens. You see? So what I want to say is it's key to look at not just this, but this in context of other minimum age policies in the country. For example, on criminal responsibility, voting, and the kinds of examples that we were talking about. Second thing I'd like to find out from you is what about what happened, because we tried to lower the age of consent in some of the countries in Eastern Europe and Central Asia, and the key issue becomes what happens with the positive test result. At that point, the child is no longer able to keep the confidentiality if the result is positive. So that's a key. I wonder how you handle that. And the third point, quickly, is that for us, when we were discussing this, the challenge is the assumption. Are we automatically assuming that the minor is competent and capable unless proven not to be? Or is the basic assumption that the minor is incompetent and therefore has to prove and demonstrate competence or maturity? So I think that shifting that paradigm, shifting the view from a view that says a minor is by definition incompetent and immature to a view that says a minor is competent and capable and mature unless suspected otherwise. That's a huge shift in attitude mentalities, but for that we need to achieve among care providers and others. I have a lot more to say, but I'll stop here. Over. Thank you.
Over to you, G, if we have you. A quick response to what happens when a child has a positive test result in the Philippines. Is the confidentiality, how are confidentiality issues handled if parents were not on hand, available, and proxy consent had to be activated to get them the test in the first place? And then the second question, what the basic assumption behind the proxy consent law and the laws in general around minor consent in the Philippines are. Is the general assumption that children are incompetent and therefore need adult consent and adult supervision, or is the default assumption that children are mature and can make some decisions on their own?
Okay. Of course, you have to have, in terms of case management of social workers, then that's one of the things that they should be on the lookout for. That when actually results are given to the young people, they should be there to be able to explain it. That's why it's not really independent access, and you don't actually guide them. You still have these service providers, the social workers should be there so that they could be able to help the child or the young person in case they tested positive. Because we still believe not all of them may have the capacity, but of course, there's also that struggle that you wanted to empower them, right? But in the case of the Philippines, it's not because we think the children and young people are actually incompetent. No, no, it's not that. The state comes in because of our parents' patrie doctrine, wherein if a family or if the parents fail to provide for the children, the state should come in. So it's basically the parents' patrie doctrine that we are employing when we look at these things. Did I answer your question, Nina? Oh, has she gone?
Fine, thanks.
Brilliant. We're a few, and thanks so much. Thanks for the question, Nina, Chewe, and for the responses. Nina, if you do have any further questions, if anyone has further questions, continue to signal them in the text box for a response at the end of the hour. We're a few minutes behind schedule. I wanted to introduce our next speaker, Kip Beardsley, who is the Director of Health Practice at the for Health Policy Plus within Palladium. Kip will be speaking directly to the issue of whether we assume minor competence automatically or minor immaturity and therefore the need for protection. And we'll be speaking about a children's consent framework that he developed in coordination with a Global Technical Executive Committee. We'd like to request once again that all lines be held on mute while Kip gives his presentation. Thank you.
Thank you so much, Lola, and thank you to the presenters before me. I think many of these issues that have been brought up and the questions that have been raised are going to continue to be further developed in this consent framework that we've been working on. So really quickly, before we move on, I want to make sure that what we're talking about here is about consent across the spectrum of HIV, medical and social services. So that is not only ability to consent for testing, but it's also the ability to consent for treatment. Because what we do find in countries is when we lower age of consent for testing, we don't lower the age of consent for treatment. So you come up with the issue that we were just describing, where an adolescent may test positive and then be forced basically to disclose to their parents in order to access care. We're also talking about consent for the sharing of confidential information. So that is also really important, of course, with everybody, but particularly in the context of adolescence and adult relationships and power. All right, next slide. Next slide. So real quick, the Health Policy Plus is a PEPFAR-funded activity. It goes from 2015 to 2020. This framework activity was funded through the headquarters operational plans 2016, and it was a combination of funding from our OVC and our HIV teams, which is really important, and it's going to come up here again, I think, in another slide or two. So next slide. So we were able to really bring together a broad range of experts to help us on this framework. You'll recognize some names up there, I'm sure. But I think what was really important here was that we had this discussion between our orphans and vulnerable children and our HIV clinical teams. Those are sometimes kind of parallel processes in country. And they have different experience, different strengths. They bring different kind of values to the discussion. And I think the discussion was richer because we were able to include a broad range of providers and experts across those sectors. Next slide. Next slide. So I want to give just a real quick overview of how we used language in this framework. We did use the term child or children for anybody under the age of 18. In the case of this framework, it's most likely going to be the children that we would call adolescents, so ages 10-ish to 18-ish. In this framework, we use the term minor as an individual who's under the age of legal consent in that country. We have a term that we call decisional capacity, and this is really at the heart of the framework of how do you assess the decisional capacity of a child. And we define this as the emotional, cognitive, social, and physical capacity to provide or withhold consent. I think the other part of the discussion that often gets lost is we're always assuming that children are going to provide consent. And the reality is that children who have this decisional capacity need to be able to either provide it or they need to be able to withhold it. It's both, and it's both sides of that conversation. And we use the term supportive proxy, so it's very similar to the discussion from Philippines. And this is an individual who, one, has to have decisional capacity, so they have to have that capacity, and they have to be supportive of the child. Because what we really wanted to make sure is that the child, especially children who may be marginalized or be from key populations, have somebody in their lives that they can trust and be there with them to help them manage these decisions about their care. This individual may be a parent, guardian, another child who has decisional capacity, and as we've also heard, social service providers, informal caregivers, or other supportive adults. All right. So the reasons we kind of worked on this was we wanted to increase the quality of care and decrease legal risk for providers. What we are hearing is that providers are often unclear or afraid to engage children in decisions about their care because the legal framework is a mess. It is inconsistent, it's unclear, or perhaps it's overly restrictive of a provider being able to have that discussion with a child. And of course, we wanted to improve access to and retention in HIV services for children. So what we also found was that in the implementation of consent, there's a lack of training, tools, and staffing. Everybody is overworked. We aren't quite sure how to do this. It's a complex issue. We've already talked about it's compounded with needs related to HIV during childhood and adolescence, and that, as I said earlier, the stigma related to key populations or other marginalized children put them at risk. So these are the kind of the context for why we jumped into this issue on the Health Policy Plus project. Next slide. So what we were trying to do was to provide a best practice policy and provider tools. So we didn't want just the policy language. We also wanted to create some hopefully easy and efficient provider tools. We were looking for consistent, harmonized, and maturity-aligned engagement of children in making informed decisions. We're looking across the health, social welfare, and education sectors, and we're looking into integrating this into existing policy frameworks and advocacy efforts. We did use an HIV lens for this activity. It was HIV funding that funded it, and there are also, specific issues related to HIV that I think warrant specific attention. However, I do think that the concepts that we came up with are more broadly applicable and can be discussed in the context of other health services for children. As we've been saying, this is really complicated, so we wanted to be clear about what the framework does not do. These are a list of issues that we do not want to get conflated with consent for medical services. We've talked about many of them before. So we can move on from there. So this is kind of the slide that kept me up at night. And it really is about this incremental kind of decision-making capacity that children develop over their adolescence. And so the challenge that we have here is that we have the orange triangle where the capacity of the child to consent is growing. And at some point, they will reach kind of that tipping point where they do have capacity to not only be a part of the discussion, but actually make the decisions. But we have this age of consent, which is kind of this arbitrary yes-no question about whether a child should be able to consent for medical services. And what actually kept me up at night was not the children who are mature for their age and who can be engaged in the discussion about their care. Maybe they're 12 or 13 and the age of consent is 16, but providers can figure out a way to really kind of navigate that. What kept me up at night actually was the child who is 16 years and 2 months old. And all of a sudden, because they have turned 16, they are faced with being the decision maker. How do we know that child actually has that decisional capacity? And how do we know that they have the decisional capacity on that day? Because we know, for all of us, we have good days and we have bad days, and for that service. So a child could have complete understanding and knowledge of what it means to have an HIV test. They understand the consequences, they're able to make that decision. After they get an HIV positive result, do they have the capacity to manage that information? Or are they going to get on Twitter and say, oh my God, I just was tested positive? Boom. So it is an ongoing assessment of the decisional capacity of the child. And I would put money on the table that providers already do this. Providers know their clients. Providers know if the client is having a good day or a bad day. They understand the context. And so I think what we're trying to do is just put a little bit of structure and documentation around this to help solve those issues related to provider risk and provider comfort. All right, next slide. So, fundamental concepts. Again, these align with what we've already discussed. We want to balance protection and autonomy. We based this framework on the international human rights documents. We wanted to make sure that the framework addressed the needs of the most vulnerable. And that's where we come into some of the discussion around supportive proxies. And we wanted to make sure that we reaffirmed that consent or assent is required across behavioral interventions, biomedical prevention, HIV testing, art, care and treatment, sharing confidential. So the ongoing consent is required. I mean, it is an ethical requirement for providers. Next slide. So the core values of consent are non-negotiable. As I just said, consent is required. But we didn't want to make the framework so onerous that there is this huge documentation and consent process for every single conversation that happens between a provider and a child. And so we did develop kind of a schematic here that can serve as a guideline for a discussion about how do we think about different levels of risk, both to the child and to the provider, and how do we align the consent discussion to that risk for that intervention. So for some of these, general audience written materials, you've got a pamphlet in your waiting room. That's probably not a high-risk intervention. It is an intervention, but we probably don't need consent from somebody to give them that pamphlet. They can pick it up on their own. They don't have to read it. I mean, that's not a huge risk. As opposed to partner notification, for example. That's a much bigger deal. And so the level of discussion, the level of documentation, whether that's a verbal consent or a written consent, it's incremental over a spectrum of services. We don't say that this is the list and this is kind of the classification, but what we're saying here is that there needs to be a discussion, and it needs to be clear either at the country or the clinic level that when we're doing this type of intervention, that this is kind of the level of conversation we need to have regarding consent. Next slide. So what we did was we delineated between consent and assent. And in the human rights frameworks, children are always supposed to assent to medical treatment and social services. Now that assent will be maturity aligned, it will be contextual, but they have to be a part of that conversation. And if for some reason an 8-year-old child is not comfortable with what's going on, it is probably in the best interest of both the providers and the child and the family to maybe take a step back and figure out how to get that child comfortable with what is going to be happening to them. So the concept of assent applies to every child, and it will have to be managed based on the maturity of that child. And the contents of assent are understanding what's happening, understanding the impact, and the ability to say, yes, no, I'm scared, tell me more, that type of thing. What bumps us over into consent is the ability to give reasons for the choice. So the ability to step back and say, yes, I want to have an HIV test, I understand its impact on me, and the reason I'm saying this is because I've had sex with my boyfriend, or I found out that my girlfriend is having sex with other men, or whatever. So to understand kind of the reasoning behind the decisions that that child is making. As I said earlier, assessing this decisional capacity is task specific, it's situational, and it's variable. It's an intrinsic part of every provider, client, patient interaction. Just because I was able to consent for an HIV test 6 months ago does not mean I'm able to consent for an HIV test today. I may be in a completely different place. And so this kind of intrinsic discussion really needs to be a part of that conversation. And the concept of supportive proxies, so for children who are just not in a place of decisional capacity on that day or in their lives yet, then that's the trigger that you have to get a supportive proxy involved in that discussion with the child. Not to necessarily completely make the discussion or make the decision for that child, but to at least be a part of that decision-making process. Of course, it can be parents, caregivers, and providers, but they have to act in the best interest of a child, and they have to be present. And so we have, later on in the tool, we actually have an assessment of proxies that says, is this proxy actually have the capacity to make decisions, and are they able to act in the best interest of this child? And there are 4 or 5 questions that you can ask to kind of guide that discussion. So this whole discussion, you'll notice I've not really talked about formal age of consent laws or recommendations. Do we come down at the age 14? Are we at age 18? We actually stepped away from that discussion in this framework. And what we really are doing is we're moving beyond kind of this binary yes-no question of age of consent to more of a decisional capacity framework. And so to implement this from a policy perspective, what's required is you need to have either mature minor clauses or some sort of clause in your legal framework, I believe like they said in the Philippines, where a child is able to consent if they understand the reasons for the test and the impact on their lives, for example. Now, mature minor clauses are a little bit tricky. You want to make sure that they are not, again, another kind of binary question, because often mature minor clauses will say, you know, if a child is pregnant, if they're married, if they're sexually active, then they have the capacity to consent. No. They just have a physical manifestation of something that has happened to them that has nothing to do with their decisional capacity. So getting back to this concept of maturity and decisional capacity more than an age or a diagnostic test. So the framework does have some practice tools. I will say right from the beginning, we did not have the time nor the money to test these in the field. They are based on what we know as best practices at the time that we did this framework. I think it would be really exciting if we had some programs out there who were giving these a shot and seeing how they worked and providing feedback on them. But they have not been tested in the field. But we do have tools in the framework that help providers to assess the child's capacity to provide or withhold consent. So there's that decisional capacity assessment. How do you engage a child in identifying who they want to be their proxy? You know, who is the person you feel safest with? Are you here with somebody that you turn to for help today, or are you scared of them? Maybe that should not be the proxy. And then the assessment of the proxy to provide consent. So I believe that is the end of our presentation. Is there? Oh, real quick. We vetted this framework in Kenya. We did an assessment of child consent policies across health, social work, and education sectors. I will just echo what has been said many times. It was a patchwork of inconsistent, conflicting, and absent policy. It was interesting because different sectors brought different strengths. The medical sector was very strong and very clear on what does informed consent look like, when is it required. The social work sector was much better at how do you engage a child in their care? How does a child be a participant in whatever you're doing with that child? Social workers had that down in their policy documents. Medical providers didn't even mention it, okay? And education sector was horrible, absolutely horrible, both in practice and in policy. We heard time and time again of children whose HIV status was announced to the class. And so there really is no policy framework for consent and for confidentiality for the education sector in Kenya. So it was a fascinating trip. The stakeholder group that we worked with.
This was which year? Sorry.
Last year. The stakeholder group that we worked with, we went through the framework with them. They resonated with the concepts of this maturity-aligned approach and thought that it was a valid thing to continue exploring. So, thank you.
Yeah. Perfect. Thanks so much, Kip. I think we can open the line for a few questions, if there are any. Feel free to unmute yourselves if anyone is speaking. *6 on the phone if you've dialed in. If no questions on the line, shall we start in the room here in New York? Catherine Langevin and then Choe.
Yeah, thanks a lot for the really fascinating presentation. I'm just wondering what are the steps to taking such a policy forward in different countries, and how does that work in terms of what's advocacy needed, what's needed in the sort of technical level, and also at the policy legislative level?
Yeah. Well, and I want to say, I want to recognize that this is not an easy sell. My colleague from the Philippines, I think, echoed that. I think the Philippine example is great because they had a broad engagement of stakeholders over a long period of time to get people comfortable with the concept of how do children participate in decision making around their health and social services. I think there are legitimate concerns and fears, of course, for the safety of children and for what this means to family structures and power dynamics that really need to be kind of wrestled with in that local context. But I would say take it really, really slow and start to share the evidence of the barriers to care and of the rising incidence of HIV amongst young MSM in Southeast Asia, for example, and that we really need to have a different way of allowing children and adolescents to have this agency to really engage in their health. So I would say my biggest recommendation would be do not rush this. It is going to be a scary concept that needs to be very gently and diplomatically introduced. Probably in very small pieces over time.
Also, just as a follow-up, I know you don't have another hour to give a presentation on your policy scan and implementation support process. So maybe we could link you with Catherine to discuss the PISSUP process and the steps in that and where you've done this, Lesotho, for example, to respond, add further context to your response.
Well, and I will say that when we did the policy analysis in Kenya, we came up with like 40 policy changes that needed to happen, like specific language that needed to be changed. Some of those were really easy to do. And so you can get some quick early wins just by changing some clinical protocols or just by doing some internal regulations and kind of inching your way towards your goal. A lot of the other things, some of the other recommendations in Kenya was just implement the policies you already have. Let's start with that. So, I think that policy change can happen with some easy, quick wins, and then kind of moving to the bigger picture over time.
And you go first.
I just wanted to make a comment. I think what you said about getting consent has to be task-specific, situational, and that it's variable is key. And that relates back to some of those discussions about when can they make a decision. And I've often found it interesting to look back at adolescent brain development and what that says about risk. People always sort of say adolescents are risk takers. They always take these risks. They can't make good decisions. But there's a time when you can make sort of cold cognition and hot cognition. So in the presence of your peers or in a pressured situation, emotionally charged, socially charged, you may not be able to make the same level of decisions that an adult might be able to in terms of assessing your risk, really thinking it through. But when you have time to think about it, you have information, you're in a calm situation, you're not surrounded by peers, those same adolescents are able to make extremely good decisions. And so allowing for that differentiation and making that clear to people, I think, is really important. So I like the way you talked about it. So that's why when legislators say, well, if they can make decisions about testing and treatment, then they should also be able to go to prison. No, that's different. So we need to keep putting that message across. I also thought it was really interesting what you said, that social workers are much better at assessing. I mean, we know that. So how do we get some of those skills to our health practitioners as a start? And then teachers, I guess that's going to be a much longer process. But thank you. I think those 2 points were really good.
Let me be the devil's advocate. So our work here and globally is to make sure that adolescents access services, and the data is appalling. They're not to the level that we want them to be. And some of this is the reason why. So I'm listening to you and I'm very excited with the conversation, but I was also thinking, how do we make this real in terms of positioning this in the broader discourse of what we're trying to do for HIV and to make sure that this population is not left behind because of some of these lack of understanding, policies that are all over the place, and the legal frameworks that don't really address what we need. I was actually thinking that in the HIV sphere, we've always figured out how to sort some of this out in terms of a public health approach. So I was actually thinking, as I was listening to you, I'm thinking that an adolescent, the age band, means a lot of things in terms of where you meet the child. But I'm wondering, in HIV, we've actually talked about a client-centered, differentiated response. So in a broader scope of things, it's the recognition that when an adolescent comes through the door or you're reaching out, they need a differentiated type of care and support, even around consent, because it depends on what situation they're in, whether they're even able to make a decision, and who else can support them. So that needs to be embedded in our thinking, even without changing policy. You know what I mean?
Yeah.
And then the second thing that I wanted to say is we also talk about the care continuum. So when you look at the care continuum in the HIV response, from testing to whatever, there's a drop in all that when you look across the care continuum. And what I heard you say is that having a consent for this doesn't mean that the other service will accept that adolescent and give them the support that they need. So we talk about the care continuum, and I wonder whether there's a packaging that we need to do that would make sense to the providers, that it's the care continuum that we're trying to pass this child through is this. And at every level, there might be need to pause to say, what are we going to do? Is this child ready or whatever? So again, it comes back to the client-centered, but within a care continuum. I think this is a beginning of a dialogue that UNICEF needs to take seriously, and we need to work, as Nina said, work within a broader framework. But I do think keeping a lens on what we're trying to do in terms of achieving results, and then addressing these issues within the frameworks that you've discussed, I think would be good. Because I do remember when we did the provider-initiated testing, we were in the same space where we're saying, no, we can't ask health workers to ask for the test and be able to pass the client through if we don't have ABCD. And it took a champion like Kevin DeCock to bring huge constituencies in one room. Some were crying, some were saying, this is not correct. And we did build consensus in the 3 days we're in that room. And even those that were crying say, oh, now I get it. But it takes that, bringing everybody together to say, for us to move this needle, we need some common language and understanding that will help us move forward. Yeah.
And I love what you brought up about kind of the continuum and how individuals tend to drop off on that. And I think the heart of this is about how do you engage an adolescent in their care.
Yes.
So an HIV test is not a one-off decision.
Yeah.
It is, for folks who test positive, it is a lifetime engagement in your health care. And the better you are at checking in and making sure they understand what's happening, that they agree with it, that they know the consequences, instead of just assuming, okay, you're going on antiretroviral therapy, we're going to do monitoring 6 months, blah, 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 here's your meds, here's your appointment, we'll see you next time. So I have no data for this, but I would say the more engaged adolescents, I would guess, would not drop off as often in the continuum.
We have one final question from Al War Online. How much weight should be put on assent in the context of adolescent-centered support? Because you had mentioned the difference between assent and consent.
Well, the guidance that we got from kind of our research really was, if it's life-threatening, you do what you have to do, of course.
Yeah.
If it's not a life-threatening decision, and that child can go back and work with their parents or their proxies or caregivers to become more comfortable with what's going to happen, and you can come back next week for an HIV test, then the outcomes, the engagement, the retention and care, the outcomes are going to be better if you can get that child to a point where they agree with what's going to happen to them. So I would say it's important. It cannot be ignored. Dissent is an important flag that something's not going right.
Indeed. And on that note, we're 5 minutes past the hour. It's been a rich webinar, rich conversations and questions. If there's any question we didn't get to just because of time, we will collate these, share with the presenters, and get you questions as part of the meeting notes. But want to thank you, Kip. Want to thank G and the team from the Philippines, Tamara, Shafiq, and Shirley for the work putting this together and for a great discussion today.
And there's a question about the findings in Kenya. There was a link to the Kenya assessment in the invitation that went out. So if you can't find that link, let us know and we can certainly get it to you.
Will do. Perfect. Have a good day, everyone. Good morning, good afternoon, good evening. Take good care.
The tools would also be very interesting to look